I'm Antonio Colombo, and I'm here to discuss where to use drug-coated balloon in current practice. Before we go to the current presentation, I want to say two statements. One, that I have no conflict to disclose, and the second is to summarize the agenda of this symposium. First will be my lecture. I will go over in-stent restenosis, small vessel and long diffuse disease. Then Dr. Bernardo Cortese will discuss Sirolimus-coated balloon and appraisal on its potential advantages over Paclitaxel. He will discuss the Katsanos meta-analysis, difference between Lanus and Paclitaxel, and then the nanolute technology specific to Magic Touch drug-coated balloon, and then present briefly two studies, Transform 1 and SIRPAC study, which are ongoing studies. And finally, Dr. Sandeep Basavarajaiah will discuss and present cases about the use of Sirolimus-coated balloon in clinical practice with real life case population. Then we'll have a roundtable discussion and conclusions. So we go directly to my presentation. First is about usage of drug-coated balloon in in-stent restenosis. If you look at the RIPS-4 study and the Daedalus meta-analysis, we conclude that there is an advantage of drug-eluting stent over drug-coated balloon. So does this mean that the case is closed and there is no room for drug-coated balloon for in-stent restenosis? My answer is no. There is room for drug-coated balloon, but we need to address two issues: optimal lesion preparation before usage of drug-coated balloon, and willing to cross over to drug-eluting stent when the criteria are not met. And I believe this aspect was not strictly maintained in a number of randomized studies and registries. And even more importantly, usage of new drug-coated balloon with better late loss, a late loss below the traditional 0.035, which was typical for Paclitaxel eluting balloons. To address the first question or the first issue, which is adequate versus inadequate lesion preparation, we published in 2016 a retrospective analysis of in-stent restenosis treated with the drug-coated balloon and PTCA prior to drug-coated balloon. And we looked at 98 adequate lesions with good preparation and treatment with drug-coated balloon versus 68 lesions where the lesion preparation was inadequate. Nevertheless, we utilized drug-coated balloon. We will not repeat this strategy nowadays, but in 2016, we really did not separate, and we used drug-coated balloon in both. And if you do that, the results are like in this curve. On the vertical axis, you see the event rate, and the horizontal axis time. In red, you see the event rate with inadequate lesion preparation, and in blue with adequate lesion preparation. You see that the two curves have a clear difference, which means that inadequate lesion preparation is a marker for poor outcome. So these lesions should not be treated with drug-coated balloon, but should be immediately crossed over to stenting. So Regarding the small vessel issue, I would say that all the topic is well summarized in the Bach small study, which randomized 332 patients to drug-coated balloon with a MACE rate of 7.5% versus 376 lesions randomized to drug-eluting stent with a MACE rate of 7.3. So basically, the non-inferiority is clearly met. The study was published in Lancet in 2018, confirming the role of drug-coated balloon to treat lesions located in small vessels. On the same issue, we conducted a few years before the Bello study, and here I would like to show you the long-term result, the 3 years result of an older technology, Paclitaxel eluting balloon, with maintained difference in blue of freedom from events at 3 years. So I believe we have also some supporting evidence that this approach works. So the small vessel issue is fairly accepted, and we have clear this area too. Lesions in a native vessel, not necessarily on the small vessels. Here you see a lesion at the ostium of the circumflex. This is not a small vessel, but is a lesion prone to very high rate of restenosis. We now try to avoid stenting. We treat these lesions with aggressive lesion preparation, in this case cutting balloon, with an excellent result. We try to utilize IBUS guidance, and then we apply drug-coated balloon without stenting. We avoid carina shift toward the LAD, and you see a very nice immediate result. And we are collecting long-term data, and hopefully in the future we will be able to give you the follow-up in a reasonable number of lesions treated in this fashion. This is the IBUS immediate with a nice cross-sectional area of 9.2 at the ostium of the lesion. Again, this is a condition to meet before applying the drug-coated balloon. If you don't get a good immediate result, you have to cross over to stenting. Another issue in a long lesions, native vessel, not necessarily small, this intermediate branch, which could be treated with a long stent, but again, to avoid the long stent, we apply good lesion preparation, dilatation in this case. Following dilatation, there is a dissection. Nevertheless, we are not necessarily afraid of dissection, and we don't leave the dissection unless we can interrogate the dissection. In this case, the dissection was interrogated with PAPD, pressure gradient proximal to distal, and there was a pressure gradient of 0.8, which shows basically that there is no flow limitation. And then we were relaxed to apply drug-coated balloon technology and do not implant the stent. A more extreme case is in this diffuse disease LAD. There is a focal lesion at the origin of a big diagonal and a lot of diffuse disease distally. You can place a short stent at the bifurcation and do nothing distally, or you can treat all the vessel, but we try to avoid stenting, especially in such a tortuous situation. We did baseline measurement of the fractional flow reserve utilizing QCA technology, basically QFR. You see the vessel all red, means that the value is below 0.7, in this case, a value of 0.62 diffuse disease starting from the diagonal lesions. We pre-dilated these vessels all the way, including the origin of the diagonal. And then after lesion preparation, you see a dissection, but again, we evaluated that this dissection was non-flow limiting. You will see later on the QFR again, and then we applied the drug-coated balloon approach to the whole vessel with 2 long drug-coated balloon magic touch, 40 millimeter long. We did IVUS as well to confirm the lumen. I don't go over details, but I just have single frames below showing a good lumen despite the presence of a dissection. And again, the final is in this slide, where you see good distal flow following implementation of drug-coated balloon or drug-eluting balloon with magic touch. And as I said, besides the final angiography here, we have the final QFR with the vessel which is not red as the beginning, with a value of QFR which is very acceptable, with a small red segment very, very distal in the vessel. So this is a very unique approach to avoid a full metal jacket, utilizing drug-coated balloon with some functional confirmation that the result obtained is stable. So should we take over some lesions that are now stented with drug-coated balloon technology? The answer is yes, as you've seen. Drug-coated balloon should be utilized in general only after successful lesion preparation, and most probably utilizing other technologies like IVUS or FFR to confirm this statement. A recent study published by Park showed that the pressure gradient proximal to distal less than 10 millimeter is adequate to confirm good lesion preparation. We used a little bit more liberal of 0.15, 0.20, and if this is followed, you can safely apply the technology. So unsuccessful lesion preparation should lead to drug-eluting stent implantation, and this should be a criteria not to use a drug-coated balloon. Thank you for your attention.
So hello everybody, this is Bernardo Cortese, interventional cardiologist from Milano, and my task today is to discuss about the querelle between Sirolimus and Paclitaxel, which one is the best one. Actually, I will not give you a final answer, but I will give you some data. I need, this is my conflicts of interest regarding this presentation. We should start from this very first slide showing the Katsanos meta-analysis and the attributed increased risk of death after PCB or PES use in the femoral popliteal arena after 2 and after 4 to 5 years. So there was an increase in total mortality after the use of this type of devices in this meta-analysis. The first thing that comes into the attention is that after 1 year, there was no difference between coated and uncoated devices in this arena. So this is quite strange because we know that, especially with drug-coated balloons, we deliver the drug immediately, and we suppose it will remain on the vessel wall for a few weeks after inflation. So this is the first point that was inputted to this meta-analysis. However, all of us know the toxicity of Paclitaxel when administered via the systemic way. And so we know that it mostly is associated with the thrombocytopenia and leukopenia. And the risk of adverse events may be very high at high dosages for this drug. We have also to admit that the release of this drug after drug-coated balloon use is quite different if compared to the release of the same drug for cancer patients during chemotherapy. So it is very different to the total dosage of drug that we administer in our patients. And to put some more fuel on the topic, there is this analysis from the group of Schneider and Zeller showing how the total dosage of paclitaxel administered to peripheral patients was not associated to an increase in death, dividing the total dosages into treated sites for the three groups of patients. So no difference depending on the different dosage of drug administered by means of drug-coated balloon. However, all of us know and remember the Taxol stent and what happened to the first patients which were treated by means of bare metal stent after drug-coated balloon, Paclitaxel-coated balloon use in the coronary and peripheral artery. We have seen an increase in thrombosis, either symptomatic thrombosis, so stent thrombosis, but also in this study done in autopsy patients with asymptomatic thrombosis. So the combination between bare metal stent, any metal, and paclitaxel is not good for our patients. Now we have understood that very well. What about the coronary arteries? This is a good news. There is no signal, at least from this meta-analysis by Scheller and co-authors, no signal of increase in total death after 3 years by means of use of drug-coated balloons, paclitaxel-coated balloons in the coronary arena. So just to put all of this information together, which is the final verdict about paclitaxel, well, I have to tell you, I don't know, but what we have to understand and to underline is that the pharmacodynamic of any PCB, but mostly of this drug, cannot be simplified to the entire drug that is loaded into the patient by means of PCI, either with paclitaxel, coated balloons, or stents, because this drug has a pharmacokinetic property that is very, very variable, and it is very variable, the drug loss during inflation, manipulation, and what it remains on the vessel wall, what goes in the flow. So it is very difficult to understand and to predict the value and the final effect of this drug. What is very important to underline is that we need newer delivery system, newer carriers, and probably also newer drugs to treat our patients with the drug-coated balloon technology. And that's the reason why sirolimus has been studied a lot in the last 10 to 12 years. It is a cytostatic drug which inhibits the mTOR portion of the cells, thus stopping the replication of the cell and so inhibiting the restenosis. Which are the main differences? We all know this slide, but I would like to underline a few points about it. Is that the tissue absorption is very different between paclitaxel and sirolimus. With paclitaxel, it's much faster. With sirolimus, it's much lower. So we have much more difficulties in order to have the drug uploaded on the patient. The therapeutic range of paclitaxel, we have seen that is very, very narrow, whereas it is much wider with sirolimus. So sirolimus can be considered a safer drug. And it also has a more potent anti-restenotic effect, also because we can also give increased dosage for the same drug. The main problem, as I said before, is that the tissue absorption is not very easy to be achieved by means of giving just the drug. All of the studies that have been done previously, just giving the drug to the vessel wall, did fail. So that's why it took almost 10 years before having the first CE-marked Sirolimus-coated balloon. And now we have the Magic Touch, which uses a quite complex technology called nanolute, It is a nanotechnology which will help sirolimus to be protected during the loading on the drug-coated balloon, the manipulation, the transit, up until we reach the lesion. And this is the first characteristic of this quite complex technology. The second characteristic is that it has a phospholipid bilayer which helps these nanoparticles or microparticles to be attached to the vessel wall and to exert their effect in the first 3 to 4 weeks after inflation. We can see clearly this by the study from Pedro Lemos, showing how the behavior of sirolimus by means of this technology is quite the same of paclitaxel, entering the vessel wall towards the adventitia during the first weeks after the intervention. And what about the drug in the other areas? Well, we have seen clearly that after 1 month, the blood concentration of sirolimus after magic touch use is 0, and it is 0 also the total dosage of drug in any other segment instead of the one that has been treated with magic touch. This is quite reassuring. And it is also reassuring the fact that this drug, it cannot be found in any other organ, either kidneys, liver, or whatever of the body. We have a few data about this study, actually much more than few to this very day. The first study was FASICO. It was a short-term registry that we did in our institution. And what we found was that the drug, the device was used very easily with a very high angiographic and procedural success, no complications, and despite the complexity of the patient population enrolled, the rate of TLR was very low after 6 months. What about the native vessel disease, which, as Antonio said before, is one of the most interesting settings for the use of drug-coated balloon? We have done the FASICO Natives Registry. It is a single center registry with core lab by cardialysis, native vessel disease up to 3 millimeters of diameter and 6 months angiographic follow-up. The primary endpoint of natives was late lumen loss. And what we have seen, first of all, is that we had 1/3 of the patients which had a lumen enlargement. This is something that we have already seen with paclitaxel, and it is good to know that we have seen the same thing with the sirolimus. And the other thing is that the late lumen loss was very low, like the best-in-class paclitaxel-coated balloons, 0.09 millimeters, with only 2 cases of binary restenosis. And then what about instant restenosis? This is a setting, like Antonio said before, it's not the best setting for paclitaxel-coated balloons. We have some preliminary data with a magic touch showing that the TLR rate after 2 years is very low. It's 2.5% at one year, but after 2 years, it's only 5.8. So it is quite the same, no late catch-up in this very difficult setting for our patients. And now we have the largest study that has ever been done with drug-coated balloons. This is the Eastern Registry. It's an all-comer international prospective registry. We will follow up the patients up to 3 years, and we have already presented a 1-year follow-up of the first 1,000 patients. What we have seen is that at the interim analysis with the events which have not yet been adjudicated after 1 year, we have seen that the TLR rate is very low and there is no thrombotic complication, and the MACE rate is low as well at 5.8%. Instant restenosis patients, the same. MI and death total were very low. TLR rate was 5.4%, like non-luteal registry, and MACE rate 8.6%, 278 patients after 1 year. And I'm really proud to say that now we are going to finish the enrollment. We have reached 1,908 patients, so we are very close to the goal of 2,000 patients. And I think that within 1 or 2 months, we will stop the enrollment of EastBourne and we go during the follow-up to see how this device is working. What about the future? We have the Transform 2 study, which is a spontaneous multi-center international study, which will aim to see in native vessel disease, which is the performance of magic touch versus science. This is a randomized clinical trial, 1-to-1, and the late lumen loss will be the primary endpoint. We will also have an OCT sub-study in the Transform 2. And then we have a Transform 1 study. This is a sponsored study, vessel size up to 2.5, lesion length up to 30 millimeters. This is the group of investigators that will enroll patients during Transform 1. This is an extraordinary group of investigators, and I'm really proud to be part of this group. In this study, the primary endpoint will be net lumen gain. And as I said, the randomization after predilatation and the absence of major dissection will be done between Magic Touch and Sequent Please, which is one of the best-in-class Paclitaxel-coated balloons for a coronary field. After predilatation, we will do OCT. So in case the patient will have a real small vessel disease, the patient will be treated with one of the two devices with a randomization in a 1-to-1 fashion. And we will have a 6-month centralized QCA to assess the primary endpoint. And the very big news about this device and the comparison with Paclitaxel is the SIRPAC study, which I will be presenting during this virtual EuroPCR as a late-breaking trial. This is an indirect comparison between the ISPOR 1-year registry data that I showed you before and the DCB RISE study with Elutax SV. And you can see here by propensity matching that there is no significant difference in terms of clinical follow-up after 1 year between Sirolimus and one of the best-in-class Paclitaxel-coated balloons. So my conclusions, Cazzano's meta-analysis is probably, it's for sure an earthquake in the field of interventional cardiology and also in the peripheral field. However, this meta-analysis is flawed by major statistical drawbacks. There is some biological plausibility showing that Paclitaxel may be harmful in at least some of our patients, mostly first-generation Paclitaxel-coated balloons. Newer devices, better designed randomized clinical trials, and long-term follow-up will be the answer in order to have more reliable data about this setting. Magic Touch is the first Sirolimus-coated balloon, and it has the CE mark either for coronary and peripheral, and it's showing very promising data. The SIRPAC study shows that it's a clinical equivalence with one of the most recent and up-to-date PCB. Thank you for your attention.
Good afternoon, everyone. First of all, I would like to thank the EuroPCR and Concept Medical for giving us this opportunity to share our experience on Magic Touch in this very unique symposium at the virtual EuroPCR. So my name is Sandeep Basavarajaiah. I'm a cardiologist in Birmingham in the United Kingdom. So in this presentation, I would like to share our experience with Magic Touch for cases and data from our real-world population. So I do not have any conflicts of interest to declare for this particular talk. So in this topic, I would like to focus on the introduction and indications for DCB in our clinical practice, followed by some data and cases from our center. So we embarked use of Magic Touch in our center since April 2018, and in so far we have used in over 400 patients in our practice. Now, the use of DCB in our practice is generally in pretty much most restenotic lesions, irrespective of the stent type, whether it's a bare metal or a drug-eluting stent restenosis. Diffuse small vessel disease, where we would not, like not to implant a stent because it increases the risk of restenosis and stent thrombosis in the long term. Important side branch ostium, as shown by Dr. Colombo, one of the case, circumflex ostium, where the Medina classification is classically 001, and it's very difficult to place a stent right at the ostium without coming back into the main branch. So this is an ideal indication for use of DCB. And finally, patients who can't take dual antiplatelet therapy for extended period of time, so especially patient awaiting a cancer surgery or any urgent surgery, if they have a significant coronary lesions, we can use DCB because you only can give a DAPT for just a month. So this is a retrospective analysis of patients treated at 2 centers in the United Kingdom. So our hospital, which is Heartlands Hospital in Birmingham and Harefield Hospital in London. So we show data from March 2018 up until February 2019. During this period, we had treated 373 lesions in 288 patients with a mean age of 66. So if you focus on the demographic characteristics, the most highlighting thing is the diabetes, which was present in almost 40% of patients. And if you look at the indication for DCB in our practice, diffuse long lesions, they're classically seen in patients with diabetes. We had around 10% of patients with chronic kidney disease, and most of the lesions were treated in the setting of acute coronary syndrome, which included 54%, and then 46% it was in stable angina. If you look at the procedural characteristics, so de novo lesions accounted for more than 60% of the cases, with restenosis accounting for around 38% of cases. Pre-dilatation was done in 92% of cases. This was our initial practice, but we have changed. Now we go 100% pre-dilatation. And most of the pre-dilatations were done with the non-compliant balloons, followed by scoring and cutting balloons, and a small proportion of patients also had rotational atherectomy. In regards to further procedural characteristics, most of the lesions were treated in the LAD D1 bifurcation, followed by circumflex system and right coronary artery. We also had a small number of patients with disease in their vein grafts and left main stem. The bailout stenting was relatively low. It was around 9%. And in our practice, we only undertake bailout stenting if there is a recoil of more than 50% or if there is a flow limiting dissection. So we had around 18 cases of flow limiting dissection which needed stenting, and around 17 cases we had more than 50% recoil. The mean diameter of the DCB was 2.6 millimeter, and the mean length was 24 millimeter, indicating these are small vessel long lesions. During a median follow-up of 12 months, all patients had at least 6 months follow-up unless they died within that follow-up period. The death happened in 10 cases, accounting to 3.4%. But the cardiac death was low, 1.7%, and the target vessel MI was also low, around 3.4%. The TLR per lesion in this complex group of patients was 12%, with an overall MACE of 10%. We had no cases of acute vessel closure documented in our experience so far. If you focus just on the de novo lesion subsets, we had around 233 lesions and 186 patients. Again, if you focus on the mean diameter of the vessels, 2.4 millimeter, indicating these are small vessels, and the mean length of the lesions were 25 millimeter, indicating these are long lesions. So the outcome in the de novo lesion group is excellent, with a very small cardiac death, 1.7%, and a small proportion of them had a target vessel MI, around 2%. And the TLR was 9%, and the overall MACE rate was 6%. Again, we had no cases of acute vessel closure. With this, I would like to share our paper, which was published just only 2 weeks ago in the CCI, the same data which I've shown, and it is online. I would like to now move on to some case-based examples from our center. So this was a case of a 64-year-old man with crescendo angina, and he had one long drug-eluting stent way back in 2016 when he had presented with inferior myocardial infarction. The angiogram this time had demonstrated an intra-stent occlusion, as you can appreciate here. So he underwent an angioplasty to this. With the help of Gaia 2 and 3 wire, we crossed the lesion. And once we confirmed the distal wire position, we pre-dilated this lesion quite aggressively with a non-compliant balloon and scoring balloons. And then we performed an IVUS, which revealed that the stent was grossly undersized for the vessel, which was 3.5 to 4 millimeter. Following this, we used 3.5 and a 4 millimeter magic touch to achieve an excellent angiographic result. As you could appreciate, there's a TIMI3 flow and no residual stenosis. So we accepted this. Patient came back for a check angiography at 6 months, and we were very impressed with the outcome of the angiogram because the artery was still open with no recoil and patient was asymptomatic. This is a case which was done recently in our center only 3 weeks ago. This is a chap who's a 50-year-old man with non-ST elevation myocardial infarction, and he had a PCI to LAD and circumflex way back in 2012. The angiogram demonstrated the stent in the circumflex had restenosed, but the LAD stent was patent. And as you can appreciate in this still picture, there is a restenosis in the circumflex ostium, and given his presentation, we thought this was the culprit. So after ballooning gently, we did an IVUS, which, as you can appreciate here, the stent was clearly undersized for the vessel. This case demonstrates that the use of IVUS is very important when dealing with restenotic lesions. In addition, there was also calcification within the stent, which you can appreciate in this IVUS. So these are some still pictures showing gross undersizing of the vessel here. So the red dots on the left-hand screen shows the actual vessel diameter or the area, whereas the one with the white arrows shows the stented segment, which was grossly undersized. So then this is another great picture which shows that the proximal reference vessel was clearly 5 mm and the distal reference vessel was 4.5. And the stent they had used was 2.5, which was taken to 3 mm in 2012. So after using a non-compliant balloon, 4.5 and a 5 mm, we used a long magic touch. But before that, we repeated the IVUS, and as you can appreciate, on the left-hand side, you could see the pre-procedure IVUS. And on the right-hand side, you could see the post-procedure IVUS, where you could see there's a significant expansion of the stent. This is another picture, so you could see this is the use of magic touch, and we had an excellent final result. Patient will undergo a check angiography in a few months' time, and I'll be looking forward to seeing this good result in the patient. So this is a third case of a bifurcation lesion. So this patient had a significant stenosis in the circumflex artery involving a large obtuse marginal and an AV circumflex. Patient also had a right coronary occlusion. So we treated this left system first. So he had a one long regulating stent to the main branch, after which we were not very happy with the appearance of the side branch, which had slow flow. So we recrossed, ballooned it, and then used a long magic touch here. Because it's a fluoroscopic image, you may not see it very well, so which is why I put an arrow. You can see the balloon. And we had a result like this at the end. Although it may not look as good as the stented segment, but we know that this will positively remodel. So patient came back for a staged PCI to RCA CTO in 3 months' time, and as you can appreciate, the angiogram of the left system looks very impressive, especially the side branch looks positively remodeled. And if you compare the pictures from post-procedure on the left-hand side of the screen and on the right-hand side, which is the, sorry. So this, the left-hand side is the post-procedure, and the one on the right-hand side is the follow-up angiography, and you could appreciate the positive remodeling. My last case is very interesting. This is a case of an elderly man who had a vein graft to his LAD, and he came in with angina. And what we noticed was that he had a significant stenosis in the insertional point of the graft into the LAD, as you can see in this arrow. The problem in treating this with the stent is that, one, there is a size mismatch between the vein graft and the LAD, and also if you do put a stent in, then you lose the future option of opening the native LAD if patient has an issue with the vein graft. So after pre-dilating this lesion with non-compliant balloon and scoring balloon, we used a magic touch, 3/0 by 15 millimeter, and the results were very impressive post-procedure. So I appreciate that there is excellent result post-procedure, and a patient came back for follow-up angiography at 18 months when he had some atypical chest pain, and as you can see, the treated segment appears positively remodeled and it looks very nice on angiogram. And if I compare the two, that is the post DCB on the left hand side and the follow-up at 18 months, you could appreciate that there is a positive remodeling of the vessel. So this is an ideal indication for use of DCB. So in conclusion, DCBs are excellent alternative to stents where they are not desirable, like restenotic lesions, small vessel diffuse disease, ostial side branch, and patient unable to take DAPT for an extended period of time. So our experience with the Magic Touch has been excellent with low rates of hard endpoints, especially cardiac death and target LMI. We had acceptable rates of TLR and MACE despite a very complex group of patients, 40% diabetic, 10% CKD, more than 50% of them were in the setting of acute coronary syndrome, and we also had a long diffuse lesions, most of them. The results are encouraging, although we need more long-term data, and it is encouraging to see so many studies which is being currently planned, and the follow-up in our center is ongoing. Thank you very much.
Okay, so thank you, Sandeep. Antonio, we have seen very, very beautiful cases with this device, and I think that you have underlined some of the key messages that should be done when we have to face DCB PCI. The first one is that it is really key to correctly prepare the lesion, and Antonio has shown us how this is clearly correlated with the failure or not of the DCB PCI. And the second point underlined by Sandeep is that you should keep the stenting rate with any type of stent as low as possible after DCB. I would like to ask Antonio one question. We have seen from the very beginning of our experience with Magic Touch that this device has a very improved trackability and deliverability. So it is easier to use this device in more complex lesions. And I would like to have your opinion on this, and if you have extended the use of drug-coated balloons after Magic Touch came into the market.
Bernardo, I totally agree with you that the delivery of this balloon is very easy. It comes in between a semi-compliant balloon and the best DS. It's a little bit on a scale 1 to 10. If you give 10 the semi-compliant balloon, I will give for deliverability this balloon 8, and the best drug-eluting stent I will give 7. So is superior to the best drug-eluting stent and is slightly inferior to the best semi-compliant balloon.
What do you think about the deliverability? Because we've seen that other devices with Paclitaxel has slightly improved their deliverability and trackability. But what I have always asked myself is that how is it possible to have, okay, we have a new concept balloon, it's working very well, but how is it possible to have such a complex technology on this balloon in order to have it very effective, but also very deliverable and trackable? So, Sandeep, how did the use of any type of drug-coated balloon change since Magic Touch came into your cath lab?
I think it is reflected in our practice that when we brought this technology to our center, I expected that we'll probably use around 20-30% of Magic Touch and 70% Sequent Neo, which we were using. But then it completely turned the other way around, where people started using Magic Touch more because it's so deliverable from the outset, and it was embarked very quickly. I totally agree that I've not thrown out any Magic Touch balloon so far where I could not deliver within 2 minutes. Whereas Sequent, Please, Neo, although the best in the, as you said, the Paclitaxel, we have issues when it comes to tortuous lesions, especially when you're delivering in the distal RCA, PDA branches. Even with the guideliner, we struggle, especially if it's the long balloons you're using.
What about your experience with native vessel disease? So we started using drug-coated balloons with the instant restenosis 10 years ago. Now we have seen some data that show that DES is probably better, not only in terms of angiographic follow-up, but also in terms of TLR, which is a hard point for us and for this type of lesions. in this setting. We have data, we have seen that Sirolimus seems to work well also in the XR setting. Also because in this registry that we have seen, there are not very simple instant stenosis lesions. So they are more diffuse. We also put in this one, for example, some total occlusions. But moving from ISR, my belief is that also the technical characteristics of this device may increase the use of this device also in native vessel disease. So in your cath lab, Antonio and Sandeep, did you see an increase in the use of DCB native vessel disease with Magic Touch, or it's quite the same as before?
Yes, absolutely, Bernardo. We have seen the usage of drug-coated balloon in native vessels and not necessarily small vessels. As a matter of fact, it is not rare that we implant a short stent in the proximal segment of the lesion, and instead of using a very long stent, we treat the rest of the lesion of the vessel with a long drug-coated balloon. By doing this, we use the stent in a focal way, and we avoid the usage of extensive stenting, and we are totally away from the full metal jacket unless you really have an extensive dissection or maybe a total occlusion with a poor result. So I think the combination of a focal stenting plus a drug-coated balloon distally is a new way to approach long lesions.
Yeah, this is the same philosophy that we share. And so what do you think? Do you think that the time has come to do a randomized study between a full metal jacket in multivessel disease and the short proximal stent and drug-coated balloon for the distal part of the lesions?
I think so, especially long stents. I think when you have to implant a stent over 30 millimeter, I believe you can do randomization between drug-coated balloon and long stent. Of course, you have to be willing to do an immediate crossover of about 20%, because in some cases you will have a dissection that you don't want to leave it as it is. But accepting an immediate crossover of 20 to 30%, you can avoid long stent in a number of lesions with all the benefit we know, including the positive remodeling that you showed pretty convincingly.
I would like to make a point and also ask your opinion on bailout stenting. Now, if I'm treating a 40 millimeter long lesion, and if there is a dissection involving a certain segment, and if I'm worried that it'll progress to a flow limiting, I tend to use a very short stent just for that segment and leave the rest of the DCB segment without a stent. Is it something which you agree, or should we cover the whole treated segment?
No, I think this is something that we have done for years. We published a paper in JACC about focal stenting, spot stenting many years ago. And we also have now long-term follow-up of patients treated with a drug-coated balloon and drug-eluting stent on the same lesion. This has been a lot of trepidation to use two drugs or to use double dose of the same drug, and we have not seen any long-term adverse event or effect. We didn't see any vessel aneurysm or any risk of late thrombosis, and we have now follow-up over 3-4 years.
I do remember that study, one of the, I think, a combination synergy, it's called synergic effect with the Paclitaxel's DCB and bailout stenting with Limus stent.
Yeah, absolutely. We We never wanted to do a prospective randomized study because we never found economical support to do an animal study that was needed before doing a randomized study, but we have really now long-term follow-up of many patients with both Limus plus Limus or Paclitaxel plus Limus with no adverse events. Okay, so I think what can we take home from these symposium? I would say that in-stent restenosis is still a main area where you should utilize drug-coated balloons, because you should try to avoid to place another layer of metal. Nevertheless, you cannot dismiss optimal lesion preparation, and I would say almost every case of in-stent restenosis should be evaluated with IVUS in order to determine if you have inadequate stent expansion. I think examples were shown in this symposium. Second area is native vessels, and native vessels does not only apply to small vessel where the use of drug-coated balloon is well established by large registry and randomized studies, but should be extended in native vessels, in some type of lesions like ostial lesions, bifurcational lesions, where usage of stents is still suboptimal. And to conclude, the availability of new drug-coated balloons able to give you a late loss, which is similar to the late loss of Limus stents, will allow to have not only immediate and short-term results similar to drug-eluting stents, but will guarantee the possibility to have positive remodeling at the long term. And please do not dismiss also the fact that drug-coated balloon does not demand long-term dual antiplatelet therapy. And this technology, even if we did not cover this aspect in this symposium, is a good alternative in patients who cannot take long-term dual antiplatelet therapy, who may need immediate surgery or some other procedure, or they are at high risk for bleeding. So drug-coated balloons are not an alternative to stenting, but are a good way to improve the result of revascularization with catheter-based technologies. Thank you for your attention.
Thank you.